Hello everyone, welcome to another lecture. Now in this lecture, we will be seeing about some high-yield topics which are more likely to be tested in any standardized exam in medicine that you might appear in. So the first of this would be hypertrophic cardiomyopathy. So let's go straight into the topic. So hypertrophic cardiomyopathy is defined as an increase in left ventricular wall thickness that is not explained by abnormal loading conditions. So the key thing here is that it should not be explained by abnormal loading conditions. For example, if you have a patient with long-standing hypertension or aortic stenosis, and if that patient has increased left ventricular wall thickness, you do not classify that as hypertrophic cardiomyopathy. That is one important thing that you need to remember. And the other thing is that it is a genetic disease and it has a autosomal dominant inheritance with variable phenotypic expression and penetrance, meaning that the disease might be severe in certain individuals and not that severe in certain other individuals. And being an autosomal dominant disease, it tends to be very common, as in it affects one in 500 individuals, and it is the most commonly inherited heart defect that you can see. And it is a leading cause of sudden cardiac death in athletes. One study showed approximately 40% of athletes who had sudden cardiac death had underlying hypertrophic cardiomyopathy. And another important thing that I would like to tell you is, you might already be knowing this, autosomal dominant conditions usually affect the structural proteins, genes which encode the structural proteins, and autosomal recessive conditions usually affect genes which encode enzymes. So as expected, this being an autosomal dominant condition is causing mutations in genes which encode for certain structural proteins in the cardiac myocytes. And the most common mutations, several different mutations are identified, but the most common mutations that you need to know are mutations involving the myosin bonding protein C and mutations involving the myosin heavy chain gene. So because of the mutation, you can see that the cardiac myocytes are arranged in complete disarray histologically, and there is also some interstitial fibrosis. So when you see histologically, the myocytes will not be organized; will be completely disorganized with some interstitial fibrosis. So I want you to remember two key things in association with hypertrophic cardiomyopathy, and that is asymmetric hypertrophy of the interventricular septum and SAM. SAM stands for systolic anterior motion of the anterior mitral leaflet. And what happens here is that you can see here, this is the normal heart, this is the normal interventricular septum. And you can see here a hypertrophied interventricular septum. And because of this hypertrophied interventricular septum, there is less space available for blood to fill inside the left ventricle. This is the left ventricle, there is less space that is available for blood to fill. And this results in reduced compliance in the left ventricle. And when the blood is flowing out of the left ventricle, it also causes a certain degree of obstruction. Now this obstruction is further worsened by something called SAM, that is systolic anterior motion of the anterior mitral leaflet. So why does SAM occur? So there is an effect in physics called the Venturi effect. Venturi effect. So what this effect is that whenever there is flow of fluid through a constricted orifice, for example, a constricted area, fluid is flowing here, and when the fluid is flowing through this constricted area, there tends to be a drop in pressure. So when there is a fall in pressure, you can see that, the pressure, a drop in pressure tends to drag things towards that. So as the blood is flowing through this narrow area, and the Venturi effect comes into play, and because of that, the anterior mitral leaflet also gets sucked into the left ventricular outflow tract. So because of this, there is further narrowing of the left ventricular outflow tract and worsening of the symptoms. And because the left ventricular outflow tract is getting narrowed in systole, and the other thing that is happening in systole is that the anterior mitral leaflet is getting dragged into the left ventricular outflow tract. There is the mitral valve is not properly coapted. So the mitral valve, instead of being closed, the anterior mitral leaflet has come into the left ventricular outflow tract during systole. So there is an opening there. So there is chance for blood to go from the left ventricle into the left atrium during systole. So what do you call this? That is mitral regurgitation. So patients with hypertrophic cardiomyopathy, along with SAM, systolic anterior motion, can also develop mitral regurgitation. And mitral regurgitation over a long period of time can cause pressure which is transmitted back. It can cause like overload on the left atrium, and from the left atrium it can go into the pulmonary vasculature, and once it goes into the pulmonary vasculature, there is pulmonary congestion, pulmonary edema, and the patients will develop symptoms of congestive heart failure. So that explains congestive heart failure, pulmonary congestion, exertional dyspnea, and all those things that you see in hypertrophic cardiomyopathy. The other thing that you can see in hypertrophic cardiomyopathy is chest pain. So does chest pain occur? See, the left ventricle, because of the asymmetric hypertrophy of the IVS, and also other parts of the left ventricle, there is a supply-demand imbalance because there is more musculature and same amount of blood vessels. So that would create a supply-demand imbalance and cause ischemia. And ischemia is also a potent trigger for arrhythmias. And the other trigger for arrhythmia, the main trigger for arrhythmia, is the structurally abnormal cardiac myocytes. Complete disarray, structurally abnormal interstitial fibrosis, and superimposed ischemia. All these are like potent triggers for arrhythmias, and arrhythmias could result in palpitation, syncope, and sudden death. And the other thing that I would like to explain to you here is hypertrophic cardiomyopathy is one condition where less blood inside the left ventricle creates more symptoms and more murmurs. The other condition which has similar findings is mitral valve prolapse. All the other conditions, all the other valvular heart diseases cause more symptoms and more murmurs when there is more blood inside the heart. So hypertrophic cardiomyopathy and mitral valve prolapse are the only two conditions where less blood inside the heart creates more symptoms. So what happens, like less blood inside the heart, what are the conditions which would plus, what are the maneuvers and what are the drugs which would put less blood inside the heart? So one thing is Valsalva maneuver. Valsalva is nothing but expiration against the closed glottis. So this increases the intrathoracic pressure, and because of the increased intrathoracic pressure, there is decreased venous return, and because of decreased venous return, there is a decreased filling in the left side of the heart also. So this is putting less blood inside the heart. So Valsalva will worsen the symptoms, and standing upright will worsen the symptoms, and diuretics which volume deplete the patient will also worsen the symptoms. And standing up, when the patient is standing upright, there is increased venous pooling in the lower extremities, and this decreases the venous return, and thereby filling on the left side of the heart. So that creates more symptoms. And diuretics, as you know, they volume deplete the patient, and because of volume depletion, there is decreased filling on the heart. That would also worsen the symptoms. The other conditions, low blood. So this is low blood volume, and the other one is decreased afterload. Decreased afterload is also going to worsen the symptoms of these patients. So how will you decrease the afterload? You by, for example, vasodilators like nitrates and dihydraprotein calcium channel blockers like nifedipine, amlodipine, and other vasodilators. So these vasodilators are going to decrease the afterload. So this will also worsen the symptoms of hypertrophic cardiomyopathy. So why does this happen? Like when you're decreasing the afterload, the gradient actually increases. So when the gradient between the left ventricular cavity and the great vessels, when the gradient increases, there is a chance for the left ventricle to empty more completely. So if the left ventricle empties more completely, there's going to be less blood, and this is going to create more symptoms and more murmurs. So you do not decrease the afterload in these patients, do not volume deplete the patient, and you do not increase the cardiac contractility in these patients. So increased cardiac contractility occurs in exercise. Occurs in exercise or drugs like digoxin. So when it comes to digoxin, exercise, Valsalva, standing upright, diuretics, nitrates, vasodilators, all these things need to be avoided in patients with hypertrophic cardiomyopathy. And the clinical features, as I said, like I just explained in the previous slide about why these symptoms might occur for these patients. The symptoms that you might see are exertional dyspnea. That can be because of failure, and because of mitral regurgitation, that the back pressure being transmitted to the pulmonary vessels, that leading to exertional dyspnea. And angina because of the supply-demand imbalance, hypertrophy myocytes and everything, and syncope, palpitations, dizziness, all these things could be because of arrhythmias, and fatigue also could be because of failure, and sudden death could be because of arrhythmias. And the sudden death in hypertrophic cardiomyopathy is most commonly seen in children between the age of 10 years to adults up to the age of 35 years. And clinically, you can see a coarse systolic murmur at the left sternal border, which is increased on maneuvers that decrease the ventricular volume. As I explained in the previous slide, any maneuver which will decrease the ventricular volume will increase the intensity of the murmur. And the other thing which would increase the intensity of the murmur is decreased afterload. So decreased afterload. The afterload can be decreased by, for example, nitrates and vasodilators. So you never decrease the afterload in these patients with nitrates or vasodilators. And the other clinical finding that you can see in this patient is double or triple apical impulse and a Bispherians carotid pulse in the presence of obstruction. Bispherians carotid pulse is nothing but you just see two peaks in the carotid pulse. So that is usually seen in tracing. So how do you diagnose this condition? So when you do the ECG for these patients, you can see that you meet the voltage criteria for hypertrophy, for chamber hypertrophy, that is the left ventricular hypertrophy, or you can see a strain pattern with T inversions. And this is highly non-specific. You can never diagnose this condition with the ECG alone. The other thing that you can do is echo. When you do a two-dimensional echocardiography, you can measure the wall thickness, and also you can see the left ventricular tract obstruction, and if you can see if there is systolic anterior motion of the anterior mitral leaflet, and you can also measure the gradient. So with all these things, like you can like without a lot of doubt diagnose the patient as having hypertrophic cardiomyopathy. And if it is not clear on echo as well, you go and do cardiac MRI. So like if you want to see soft tissue structure, delineate soft tissue structures more precisely, the diagnostic modality of choice there would be MRI. So in line with that, we go ahead and do a cardiac MRI and confirm the diagnosis. The other thing that we do is genetic testing. So genetic testing can be done if there is a high index of suspicion of cardiomyopathy, and you go ahead and do genetic testing. And genetic testing returns positive in about 50% of patients. So positive echocardiographic findings, clinical symptoms, and go ahead and if you have done a genetic testing and identified one of the mutations, and you can say without reasonable doubt that the patient is having hypertrophic obstructive cardiomyopathy. And one key point to remember here is that when you're doing the echocardiography, the diagnostic criteria here is the maximum left ventricular wall thickness should be 15 millimeter or more in the absence of another disease that could cause it. Like there should be no other disease like long-standing hypertension or aortic stenosis that could cause it. And it has to be accompanied by supporting information like family history of sudden cardiac death, positive genetic testing, and systolic anterior motion of the anterior mitral leaflet on echo. So with these criteria, you can diagnose the patient as having hypertrophic cardiomyopathy. Now coming to the treatment. So when the patient is diagnosed as having hypertrophic cardiomyopathy but is having no symptoms, you can't do anything about that. You can just go ahead and give some lifestyle advices to the patient that they're not supposed to do strenuous activity or participate in contact sports. So that's the only thing you can do. There is no role for infective endocarditis prophylaxis. There is no role for any prophylactic medications. So when the patient has symptoms, the treatment has to be focused on symptomatic relief and prevention of sudden cardiac death. So how do you do that? So as I said before, beta blockers. So what do beta blockers do? Beta blockers reduce the cardiac contractility and reduce the heart rate. So if the heart rate is reduced, there is more time for the heart to relax. So when the heart is relaxed more, there is more blood filling inside the heart. So as I said before, more blood, less murmur, less symptoms, less blood, more symptoms and more murmurs. So beta blockers are one of the first line drugs which can be used in hypertrophic cardiomyopathy with symptoms. And the other thing is non-dihydrobiopterin calcium channel blockers. This will be drugs like verapamil and diltiazem. These drugs will also like reduce the heart rate and give more time for the heart to be there in diastole and fill with more blood, and more blood, less murmur. And the drugs you can see here are verapamil and diltiazem. You can't give drugs like nifedipine or amlodipine, the dihydropiridine calcium channel blockers, because those drugs decrease the afterload. As I said before, decreasing the afterload can be very dangerous in these patients because decreasing the afterload will end up will end up increasing the gradient, and when the gradient is increased, the left ventricle can empty more completely, and if it is more completely empty, like there will be less blood, and less blood will create more symptoms and more murmurs. And when you're giving diuretics for a patient with failure, as I said before, patients with hypertrophic cardiomyopathy can go into failure also because of the accompanying mitral regurgitation, which could occur due to systolic anterior motion of the mitral leaflet, and over a long period of time that can result in congestive heart failure. So patient is having congestive heart failure, and there is increased pulmonary artery systolic pressures. And what do you do in those cases? You definitely have to diurese the patient, but you should exercise extreme caution when you're diuresing the patient. So if you over diurese the patient is going to get volume depleted, and the patient gets volume depleted, there are going to be more symptoms and more problems. And you avoid nitrates and vasodilators at all costs because of the reasons that I mentioned before. You're decreasing the afterload. And digoxin. What does digoxin have to do here? Digoxin is a cardiac inotrope. So cardiac inotrope increases the contractility. So when anything which increases the contractility causes the left ventricle to empty more completely. So when the left ventricle empties more completely, there is less blood inside the left ventricle, and that could create more symptoms and more problems for the patient. So digoxin also needs extreme caution. So what you need to remember is the only drugs which are very safe here you can see are beta blockers and the non-dihydropyridine calcium channel blockers. And diuretics you can give when the patient goes into cardiac failure, and just diurese the patient for some time and exercise extreme caution, keep monitoring the patient with echocardiography, and do not over diurese the patient. And the other treatment modality that these patients have are ICDs. ICDs are implantable cardioverter defibrillators. So ICDs, as you know, are part of device therapy in patients with heart failure with reduced ejection fraction. So patients with heart failure and reduced ejection fraction can have life-threatening arrhythmias and can have sudden death. So what these ICDs do is they recognize a malignant rhythm and they give a shock and try to revert it back to the sinus rhythm. So employing the same concept here, considering that these patients are at high risk for developing malignant ventricular arrhythmias and sudden cardiac death, ICDs can be a choice in these patients. And who are the candidates in whom ICD is inserted? Patients who had a prior cardiac arrest, those who have a recurrent unexplained syncope, left ventricular hypertrophy with maximum wall thickness 30 millimeter or more, or if there is family history of sudden cardiac death in a first degree relative, non-sustained ventricular tachycardia on Holter monitoring in patients who are less than 30 years of age, and hypertensive response to exercise. So just go ahead and try to remember these conditions like prior cardiac arrest, like family history of sudden cardiac death, recurrent syncope, hypertensive response to exercise, and NSVT and Holter. So some other conditions where you can go ahead and insert an ICD in patients with hypertrophic cardiomyopathy. And the other treatment options, surgical options that are available are surgical septal myectomy, catheter ablation of the interventricular septum. This is also done of the IVS, interventricular septum. And one thing that I would like to tell you is once the abnormality of the interventricular septum is corrected, the systolic anterior motion also corrects. So systolic anterior motion also corrects. Why does it correct? Because I told before, systolic anterior motion is because of the Venturi effect. So as the blood is flowing through a narrowed orifice, that causes a reduction in pressure. That reduction in pressure is dragging the anterior mitral leaflet and causing the further obstruction of the left ventricular outflow tract. So if you could correct the asymmetric hypertrophy of the interventricular septum, and if the blood is not flowing through a narrowed orifice, if the blood is flowing through a wide orifice or a broad orifice, there is there is no possibility of the Venturi effect occurring and dragging the anterior mitral leaflet along. So that would correct by itself. But in case the mitral valve is also chronically damaged, for example, it's long-standing, in those cases, mitral valve might also be needed to be replaced while you're doing a surgical correction. And the last option is cardiac transplantation. So this explains some of the key points which are associated with hypertrophic cardiomyopathy. Hope you got to learn something from this video. And if you want more such videos, subscribe to this channel and keep watching.